you very much. Thank you very much, Paul. We have half an hour for questions, and one of the rewards I get for being the moderator is I get to ask the first question. So I will begin my question by asking Carmela a little bit of a clarificatory question. One of the issues that we are trying to grapple with is how do these various methods fit into each other, and what do they presume? Would it be accurate to stay with this Peirce, QI, QA thinking that COPE, in order to be ideally successful, presumes a lot of competency of frontline workers, a lot of standards already visible, because now the focus is you are competent, you know what to do, how can we sit down and make it actually happen? Would that be a good assessment of the environment?
No. What COP will do is that it will help to the facilities to identify precisely what they are missing as providers' skills and knowledge, standards that they need, protocol, policies, and they will help the providers at the facility to understand that they are missing that and embrace the need to get more training that can be attained by clinical in-service training, or the need to have and apply the standards that the Ministry of Health may have already developed, but they are, as someone mentioned, just in the office of the manager and not be applied. COP will look at a range of issues, and the thing is that the participants, the staff for a facility, will identify little things like what I mentioned, the need of benches for clients to sit down while they are waiting, to the need to improve the technique to perform any procedure.
So the standards will come from the facilitator. Who knows what the standard is?
No, the standards will come from within the same institution. And let me explain something else a little bit. The self-assessment guidelines, there are self-administered guidelines, are developed based on the internationally approved endorsed standards and are organized following the client's rights are providers' needs. Let me give you an example. We have a guideline that is about safety. So in that guideline about safety, the providers are going to ask, are all the clients provided with the method of their choice, if we're talking about family planning? Are the clients assessed for fitness for service provision? So the standards may or not may exist to guide the service. The standards are implied in these self-assessment guidelines. And that's why we said that the self-assessment guidelines need to be updated over time. There is not something that we will develop and we will put there to be used over the years. It needs to be updated according to changes on the standards, and it needs to be also adjusted to the context of the.
Yeah, I think I have a little bit more clarity.
But a little bit more?
Open.
I guess I asked Paul, what is the difference between or relationship between accreditation and certification, and specifically professional certification, and their maybe and their bodies? How does all that interrelate?
Yeah, the three terms, for sake of brevity, I took out the definitions of licensure and certification. Licensure is usually, as I mentioned, something done by a governmental agency to establish a baseline. It usually codifies law and regulation in the country, and it's to protect the public and it keeps people from entering the field who should not, as individual providers or as organizations, advertise their services as healthcare. So It's more a government action, whereas certification usually means that the organization, or in some cases the individual, has unique extra capacities or knowledge. So you could have a certified mammography center, or an individual could be certified in some procedure that they do. So it's usually something in addition. It's not a whole facility. It's just a particular, you could certify a diabetes program, or you could certify a joint replacement program, or so it's just a piece that has extra capacity. Usually means the individual or the program uses good science and evidence and has a process of continual assessment and improvement. So those three terms frequently get confused.
Thank you, Paul. Next question, Enrique.
Thank you. It's to Paul also. But before just a commentary, the differentiation between accreditation, certification, licensure, it also varies among countries. So we should be aware of that, because we might call something in a country and it means different things. But my question, Paul, is how do you differentiate between external quality evaluation and accreditation? You mentioned that at the end of your presentation. You said it's better to think now maybe on this rather than accreditation.
I mentioned that for a couple of reasons, and I'm a little congested, so I think I heard your question right. Why did I say we should use different terminology with external quality evaluation? Well, one is just the experience that we've had with SafeCare, which now has over 1,500 clinics certified or evaluated in a lot of countries. And it's when you take the mystique out of accreditation and you say, this is simply quality evaluation against standards. To me, you diffuse a lot of what people are thinking of and hear and read about accreditation, and you distill it down to the essence of it. It's standard-based quality evaluation by a third party that grants you some kind of recognition. And I think that opens the thinking up, especially in low and middle income countries that are used to knowing, well, they've had accreditation in the US for 100 years, and this premier hospital is accredited. We could never be like them. But it does open up the fact there are other ways that you can incrementally improve and reach that. The other is that the International Society for Quality is beginning to look at a wide variety of external evaluation processes that are not accreditation. If you look at Plaintree, they go in and look at the environment of care, patient focus. So there's a lot of quality evaluation processes that give recognition, but they're not accreditation, but they're valuable because they're standards-based and they're credible. So I think the field is starting to break open a little bit to widen our thinking on the whole area.
Thank you. Jillian, you had a question?
Okay, that's better. This came from the webcast. She asks, can the panelists address the sustainability of their approaches and how they might be best institutionalized?
Begin, maybe we can start with you, Edgar.
Very briefly, is the possibility of...
So let me repeat the question. I understand. Can the panelists address the different approaches and the differences between them? The sustainability of these approaches.
Yes.
So very briefly, the perspective of sustainability of an approach depends, from my point of view, how it is incorporated into the normal managerial processes of the organization. And to us, one of the key systems is the supervision, but not top-down supervision only, but one that involves clients, frontline providers, etc. So that would be the possibility, and that's have been our experience too. When we get into that point, we have better chances of sustainability, including the policy levels, as I mentioned.
I agree with Edgar, and I just wanted to add that sustaining a quality improvement service or approach or a process, it will require monitoring all the time. It's not something that we will introduce and that will live at their own. Even here at the States, what I have learned is that they need the ongoing accreditation, the ongoing training, the ongoing making sure that they fulfill with the standards. So sustainability, yes, but it will require support.
For accreditation, I think it's having your stakeholders lined up from the beginning. You have to add value to those that pay for care. You should be giving them information. You have to add value to the healthcare practitioners, making it better settings for them to practice. You have to add value to those who use accreditation as a proxy, say for medical travel or some other reason. So having those stakeholders lined up is really essential at the beginning for sustainability. And with that then will come the finances, and it depends on whether you're private, for-profit, or not-for-profit accrediting body, or whether you are quasi-governmental or so. But having the stakeholders lined up, they will make the case for you for funding and sustainability if you do it right.
Thank you very much, Paul. The gentleman in that beautiful red tie.
Is this on? Yes, it is. Gary Filerman, best described as former. The good news in this discussion, I believe, is the attention that it's paying to low-resource hospitals. The missing link in the conversation of strengthening health systems, and yet the place where most people go for most of the care, most of the time, in most of the population centers that we're concerned about. The bad news is that I don't hear in the conversation recognition of the implementor at that level. We've all met that implementor. That's Dr. Blanco, who is the superintendent or the director or the owner of the hospital. This is the person that establishes the context, reaches out, is most responsible for sustainability. This is an individual who has no training for their job, sees themselves primarily as a surgeon, is in the office for 4 hours at best a day, signing papers, and then goes to the consultation room. We've got to pay attention to the translator, to who we're addressing here at the operating level, who is going to open the door and assemble the resources and assure the sustainability. We use the word institutionalization. Who's going to institutionalize? We've got to direct our attention to that individual at the front line.
Will just support his point. I think that, yes, we need to make sure that whatever quality improvement process we implement, we pay attention to that person that will be kind of what Paul was saying, will be the one that support the activities.
To have champions, basically.
Yes.
Thank you. Mike?
Thanks. I've got two questions for the panel, and maybe the first one is a sort of wider consideration. When you're working with countries, and in the panel you've worked with many countries, have any of them ever asked you for what evidence supports your proposed intervention? And if not, why not? Similarly, that goes if in research, now you have to have done a systematic review before you, as part of your proposal, to establish that there is uncertainty. Because if there's already certainty, your research is a waste of time. if there's uncertainty, then when you go with a proposal to a country, isn't it actually a research element that you need, not selling them a program of what, because you think you know that it's working? So that's, I think, a wider issue about where we put systematic review and assimilating the evidence before we conduct major programs. The second question is really about capacity. Again, you're representing organizations that have worked in multiple countries. And it touches on this issue of sustainability. So in the country that I know very well, which is over 40 million people, there are about 8 people in the government responsible for monitoring and evaluation. And that's at the national level. And there are about 6 people responsible for the health information system. Most of those 14 people have at best a master's qualification. Can we do anything about sustainability without really tackling long-term capacity elements when we're talking about quality? We can run program and program and program, but if there is nobody to hand things over to, then can we talk about sustainability?
May I ask you, Edgar, if you have a comment to offer?
Well, very interesting questions and difficult to answer, but I will say, in our experience so far, or particularly in the past, we relied, when we talk about the approach, on how intuitive was the approach, how it made sense. And the leaders, we talk with ministers, with vice ministers, with directors, they said, right, seems to make sense. So let's do it. That was, and for us was good, because as I said at the beginning, our approach is heavily oriented to action, not to creating more evidence at that point. However, lately, there is more demand for evidence, and this is an important discussion, because and now some missions and some, what is the evidence? Fortunately, we have some evidence now. Not, as it was said, is not like say, wow, this is definitely the, but it's some evidence that supports us. But my point here is, and your question is extremely important, because at some point in this field too, we will start to weigh how much goes into creating evidence and how much into implementation. Because, for instance, when we talk about the strengthening the health information system, do we understand what does it mean? I think probably we could spend 10 years in improving the information systems, and they won't be enough to say this is the evidence, like in the United States. So the costs have to be, there is limited money, have to be allocated to something. But it's a very important discussion, how much goes into each side. And that's, I guess, leads to the other situation around institutionalization, which I left in my presentation as still an open question mark. We try to put this into the system, but if the systems are weak, is difficult. It's a, I would say, work in progress still.
Your question was interesting in that I don't think I've ever been asked, what's the evidence behind accreditation? I can't think of any situation. The terminology is usually, what's the value and what's the impact, which is a little different than the evidence. So, I mean, that's just an observation which kind of triggered that. You know, I've never gone into talk to a hospital CEO with a lot of printouts of research and things like that. You want to be prepared to talk about impact and the value. The other thing on sustainability, I like to look at the other side, to take a look at the accreditation programs that have failed. And I think the ones that come to mind, they lost the public trust. They didn't have transparent processes. Decisions got bogged down in politics, favoritism, and everything, and the program went out of business. The other ones that weren't sustainable were totally funded from outside sources, and when that disappeared, the program disappeared, and Jim referred to that earlier. So the programs like Safe Care, where it's all the people, local people trained to do the work, is a very different model. But that's an interesting question.
Very interesting question, and I think that is that question that brought us together here. That's exactly why we are analyzing these 6 methods, because USAID have put a lot of money on using this method, but the evidence that the impact of this method is doing what we expected is weak or non-existent. And in the meeting of November 14, I mentioned that one of the problems that we have had to gather that information is because the same donors that were supporting us to implement and to do and to go to action, as Edgar was mentioning, was very shy in providing funds to us to document and to evaluate the approach. Because in their words, they say, it works, what we need to do about it. That's one point. The other point is exactly, it's not just capacity, it's not just sustainability, but James put it very well also in November when he said we need to look at the efficiency and the need of external consultants and the capability of scaling up, et cetera, et cetera. So your question is core to what we are trying to do.
Come back a bit, just to, so do you think there's a role for institutions like USAID to empower governments to say, when a program is offered, show us the evidence that this program is a good investment? I mean, that should be what governments are deciding now, not just being told, here is so many $1 million for this program.
If I could just make a comment. Our consulting arm for JCI has gone into many countries and helped them develop their own national programs. The biggest failure of that work is we haven't put in a set of metrics to know whether it was a success before we developed the program and implemented it. So, once you're on the trail of, developing and implementing, it's too late already.
Ramanan, you had a question?
A very quick question about so again, the thought that accreditation is somewhat different than the other methods, right? So that's, I find it difficult to sort of put them all in the, compare that versus the other. Are there examples of countries where, one of these other methods was used as a quality improvement approach in systems that either require accreditation versus not? In other words, do we know whether accreditation actually drives particular facilities or systems to go after a COPE or one of these other quality improvement methods? Maybe these never actually intersect, but I see the accreditation as entirely different. That's a, that's not a process. That is more of the, what one might expect is something that that health systems want to acquire as a signal of them having quality. Of course, the process of accreditation is itself quality enhancing. I think you've made that case. But even so, I think, for a hospital to say, I have Joint Commission accreditation is really to wave a signal. So do we have examples of intersections between these methods and accreditation processes?
I can partly speak to it, but the accreditation standards set the framework for how the organization should run. The principle that everybody, say every staff member is competent to be doing what they're doing. They have a job description, their performance is evaluated. So that's the framework. Then others come in and help with the tools and understand how to do that.
Any examples you can think of? Any places?
My question is more for Kamala and Edgar. In the examples that you know of, has anyone ever said, we're trying to get this accreditation and we'd like to use your process?
Well, I'm not down at that level in our organization, so I can't pull up some examples for you. So if I can make a quick call, I might come up with a couple.
No, in accreditation in African countries is not very widespread because of what's said here, the infrastructural requirements. So we don't have, except South Africa maybe, so the projects didn't intersect much. In Asia, Indonesia, for instance, was doing accreditation, and we were doing our process there, but again, they didn't intersect because the standards were not necessarily leading one to the other. Maybe this is something that can be worked out, as Paul was saying, with the pre-accreditation, what SafeCare is doing.
I cannot mention any example where I can say in this country they did this to get the Joint Commission accreditation. But I can say that in Latin America, a lot of countries implemented all or some of these quality improvement tools to get some accreditation. May it be accreditation from their own government or accreditation from other bodies like UNICEF, and they wanted to be called the friendly hospital for kids or something like that, and they needed to comply with a lot of things. So yes, the two processes have been tried together, and I think that's a potential area that we need to assess.
I could just
I know.
want to make sure that you don't substitute JCI accreditation for a national accreditation program. Okay, because we think every country should have a national accreditation program and every hospital should be accredited by them before they approach us. Because we're trying to tie people together internationally. They need to meet the norms of their country first.
So I know a number of people have been waiting with a number of questions. I'm just going with the order in which I got them. So Sheila, maybe is the last question because we don't have enough time beyond this. I'm so sorry.
Okay, thank you. With the caveat that we started the day saying that the evidence around quality interventions is much less than we would want across the board. I want to ask a question because I appreciate your candor, Carmela. You said that the evidence was weak or non-existent. And I think we should ask the same question of Paul and Edgar then to characterize what you think the evidence is for accreditation or for SBMR.
Okay. As I was mentioning in my presentation, we have some comparative studies. At this point, we have 5 comparative studies. All of them show advantages towards the site of the intervention. Not completely in some of them, and it's complicated to find comparison groups for the many reasons that have been discussed here. That's the evidence we have at that level. The other is the type of evidence that I show here using improved service statistics and validating it to triangulating methods, including the quality of care survey, which are independent external evaluations. But in general, as I was saying in my presentation, the evidence is not strong. It's partial, it's initial, and mostly, except the example of Mozambique that I show, is limited to small samples.
Thank you very much.
You know, in the presentation in the fall, I tried to pull together the literature on research related to accreditation. And as I admitted at that point, mostly what you get is there seems to be an association between accreditation and quality and good outcomes. And I think that the reason for that is that we haven't figured out how to research accreditation yet. It's a methodology that's applied differently. Every accrediting body in the world does it differently. So it's really hard to study. It really means almost a country-specific study, such as in Jordan, a new accreditation program. You have the opportunity there to study it in an environment that you can do a controlled study. So I think there needs to be a lot of work on figuring out the correct methodology to study accreditation.
Do we stop here?
Yes,
there are a
I'm
number of
afraid.
people waiting to allow some more time.
Okay, I'm going to
Gillian?
ask, do you want to stop here or do you want to have any more
I think
questions?
maybe people can hold their questions for lunch.
Okay,
Okay. Thank you to my panelists. Thank you very much.
thank you.